This really brings me to kind of, one of the critical components of curative intent, which is liver transplantation. Riad, so who goes to transplant?
So in general, the criteria for transplantation are based on a seminal article in the mid-90s in New England Journal talking about the ability to provide long-term survival in patients with HCC. And they're often referred to as the Milan Criteria. And they refer to the ability to transplant a patient with 1 lesion, 5 centimeters or less, or 3 lesions less than 3. Those are often called the Milan Criteria. But these are the people that we review in multidisciplinary tumor board. And if feasible, and if they display these tumor types, then liver transplantation is something to consider, possibly a curative intent.
Laura, you're from the same institution. Do you go beyond the Milan? And tell us, what does it mean to go beyond the Milan?
So going beyond Milan would be a larger tumor greater than 5 centimeters or more than 3 lesions or 1 greater than 3 centimeters. And I think we do, and many people, why the Milan criteria have served us well since its implementation, feel that this is too stringent. And there are people that we think would do better with a transplant. It's the only potential curative option in many patients. So what we try to do is downstage patients with a liver-directed therapy, give them a test of time. And this has now been seen in UNOS, which governs transplantation, that patients are now mandated to wait 6 months before their actual scoring system of points that awards them priority on the transplant list starts to kick in. Because what they're trying to do is kind of weed out patients who have a very aggressive behavior, despite the fact that they're within the Milan criteria. But there are patients who are beyond the Milan criteria who don't have an aggressive tumor. And by using liver-directed therapy to show downstaging and also AFP levels that go down to normal, those are patients that we think would probably benefit from transplantation.
I like what you're saying, but also to challenge the point about, probably, in other words, you're bringing here a variable that probably in the beginning it was not looked at, which is the dynamic component, which rather was more defined. But the metro ticket story kind of still valid. So can you tell us what metro ticket is, and same time, what does it mean?
The concept is, if you are on a train, the longer you go on the train, the higher the price. So the analogy
is Europe, not here. Fair. Okay.
The larger the tumor burden, the greater the chance. And we've known that once you start reaching a tumor burden of 5 centimeters, there's about a 50% chance that you're going to have vascular invasion present on explant, which has been the highest chance of recurrence. And as we know, post-transplant, once people recur, this is their #1 cause of death, and we don't have great treatments for them after that happens. So obviously, you want to try to prevent that from happening. So yes, you're right. We want to make sure that we're not going beyond, but there are so many people who would benefit, and we're transplanting people with very early disease, and with the role of liver-directed therapy, and Riad can probably talk a little bit more about this, where we may challenge that some of the liver-directed therapies may be considered curative for a 2-centimeter solitary lesion, as opposed to going right to transplant and then shuffling those livers to patients who have more advanced disease beyond the Milan criteria.
Before I tackle surgery or anything else in regard to curative intent, I think Laura brings a very important point. Katie, so what's downstaging, and especially in transplant setting?
So I think many of our groups, including my colleagues at UCSF in hepatology and liver transplant, have done a lot of work looking at which patients with tumors larger than Milan criteria can have equivalently good outcomes after transplant. And what we've seen, I think, across a variety of studies in multiple institutions, is that patients whose tumors can be decreased in size to within Milan criteria with the use of interventional radiology downstaging, such as chemoembolization or Y90 increasingly, can have equivalent outcomes to a patient who started out within Milan criteria. And this is akin to what we see in colorectal cancer too, that patients who are converted to resectable over time often will have as good of an outcome as those who started out resectable to begin with. So in the case of downstaging, we think that, and the data bears out, that patients who can be converted to Milan criteria by a combination of liver-directed arterial therapies have the same outcome as patients who started within Milan over time. And there are poor prognostic factors that suggest patients won't make it in downstaging or will fall off the waiting list during this process, such as a high alpha-fetoprotein value greater than 1,000 is one of the cut points that's been looked at, or lack of response to downstaging, so a tumor that doesn't respond well to TACE. Those patients often don't make it in the downstaging process and are weeded out by poor biology tumors. But in general, patients who respond well to TACE, who have an AFP response and a response decreased to less than 1,000, can do as well as Milan, patients who start out within the Milan criteria.
Fascinating. No doubt that, you know, the transplant field is was put into a highly choreographed and well-designed approach, as, you know, Dr. Salem referred to the Mazzaferro study from the New England Journal of Medicine. But obviously, no doubt that we are still trying to understand that field better. And the points that you heard about, you know, especially expanding beyond the Milan and this especially new advent of the UNOS, kind of like the 6-month wait before the points start kicking in to kind of consider who's coming for transplant with HCC, add to, of course, the downstaging, definitely will probably invite any of the physicians to make sure that we have a patient who really is still in the local disease setting, to make sure at least to get one opinion from a transplant center to make sure that, you know, these options are definitely visited and looked into.